Good afternoon, and thanks for joining us for The Art and Science of Surviving Cancer. I'm Greg Berry, Director of Communications in the Office of Alumni Affairs. Since we're virtual, please excuse issues that may pop up, and if you have problems with your video or audio, click the reconnect button to return to the webinar right away. As we begin, I just want to throw a poll out at you. I want to know the makeup of our audience better. In the poll, please select which one represents you the best. I'm a cancer survivor, I have a family member or friend who is a cancer survivor, or I'm interested in learning more about this topic. Let's go ahead and launch that. I've got it activated now. It's just which one is the best that describes you. I know a lot of these may have overlap, but go ahead and make that selection. I'm going to leave that up for a little bit so you have a chance to submit your response. For our live participants this afternoon, this webinar is being recorded and will be uploaded onto our website. As an attendee, you'll be getting an email with the link once it is ready. Today, we welcome Dr. Smita Bhatia to our webinar series. Dr. Bhatia completed her training in Blood Banking and Hematology, Oncology and Epidemiology from the University of Minnesota. She joined UAB to establish the Institute for Cancer Outcomes and Survivorship back in 2015 and is the White Endowed Professor in Pediatric Oncology. Before we begin today's presentation, here are the results. About half of our audience is a cancer survivor. About 20% has a family member or friend who is a cancer survivor, and 33% is interested in learning more about this topic. So at this time, I would like to welcome Dr. Bhatia and turn things over to her. Thanks so much for joining us and taking time out of your day.
Thank you so much. And I believe it is good afternoon now, although I like to say good morning till I go to bed. Here we are today discussing cancer survivorship, the art and science of surviving cancer. I'm a pediatric oncologist, so my focus is going to be on childhood cancer survivorship. So everything will be through the lens of childhood cancer survivorship, but it's important to know that most of the principles apply also to adult cancer survivors. So the biggest hurdle in the talk is how I'm going to start it. So bear with me as I share. And then you have to tell me whether you can see it.
You are rocking and rolling. It's all yours.
Right. Okay, then let's get going. So let's start the topic by, why wouldn't it like to move?
Go to the back end where your slides are, and they might be able to. If not, you know what? I can share my screen and I can advance them.
No, it's moving.
Oh, there we go.
All right, then. So sorry, guys. Here we are. We'll start by trends in survival rates in childhood cancer. And it takes its time, Greg.
And that is no good.
No. Something has happened. Yeah, so I don't like this, but we'll try and see if we can muddle through this. What I'm showing out here is survival rates in the 1960s, where only 10% of the childhood cancers survived. In the 1970s, when 61% of our children survived 5 years at least from cancer diagnosis. And then today, where over 85% of our children survive cancer, i.e. they become 5-year cancer survivors.
You know what? Let's do this. Since there's a lag, we are going to...
Will you share?
Yeah, go ahead. Stop sharing. And I am going to start here.
Okay.
And down at the bottom where it says next.
Oh, beautiful.
So the only bad thing, just for your heads up, any of the transitions, any of the building of the slides will not happen.
That's fine.
Perfect.
As long as everybody can see the slides.
They sure can.
All right, then. So, but what we have to remember is even though the survival rates have improved so tremendously, our childhood cancer survivors and our adult cancer survivors carry a tremendous burden of morbidity. Amongst childhood cancer survivors, we know that by 45 years of age, 95% of people who have survived childhood cancer will develop a significant health problem that is directly related to the childhood cancer diagnosis or its treatment. 95%. And here are some of the examples. Here I'm showing you a joint, a hip joint that is completely destroyed because of the steroids that we used to treat childhood cancer. I'm showing you a mammogram with breast cancer, this shadow that you see detected on the mammogram, directly related to the radiation we used to treat a young girl for lymphoma, and she then developed breast cancer. We treated a young child with acute lymphoblastic leukemia, and we had to give cranial radiation or radiation to the brain, and then he came back with a brain tumor directly related to the radiation. We have to use anthracycline chemotherapies in about 60% of our children with cancer, and a high proportion of them develop heart failure. Here you see a large flabby heart, which is not able to pump out the blood as we would want them to. Another important and sobering outcome is the fact that our childhood cancer survivors are at a 6-fold higher risk of premature death, and their lifespan is shortened by 1 to 2 decades. And in this slide, what I'm showing you is the baseline increase in mortality rates in the general population. So we all know that as we age, we are at a higher and higher risk of dying. But here are our childhood cancer survivors, where the mortality rate for primary cancer relapse increases initially, but then plateaus off. But that due to other complications which are treatment related, such as heart failure and new cancers and osteonecrosis, those conditions start climbing up. They cross over the relapse related mortality, and there's no plateau seen at 45, 50 years of age in these survivors. So as I've been trying to say, there is clearly defined associations between treatment exposures and chronic health conditions. Here we show you that anthracycline chemotherapy and chest radiation place a childhood cancer survivor at high risk for heart failure. Radiation and certain kinds of chemotherapies listed here increase the risk of second cancers in these patients. So then the question comes up that when a child comes to my clinic with a newly diagnosed cancer, I have to do treatment. I have to treat that child. I have to give them chemotherapy and radiation depending on the type of childhood cancer that they have. And based on their age and based on whether they are boys or girls, they are at risk for developing these long-term complications. However, certain things increase or decrease the risk for these children. It could be genetics. It could be whether they engage in certain lifestyle exposures, such as smoking and alcohol consumption, or it could be added viral infections, which place these children who've been treated with chemotherapy and radiation at higher risk for developing these complications. But what we can do is use all of these data points in order to identify who's at the highest risk of developing these complications, and then we can upfront modify how much treatment we're giving. We can screen more intensively those who are at the highest risk, or we can use some risk reduction strategies, which I will discuss, in those that are highest risk for developing these complications. This is something that we've learned over the past 2 to 3 decades. We've learned that if you have a certain chemotherapy or radiation that you're using in a cancer patient, some of the survivors will develop long-term complications. But who develops it and who doesn't develop it so far has been a black box. Now, with modern techniques, what we call molecular biology, i.e. going into the DNA level and the RNA level, we can see what actual dose goes inside that one particular person. Is it an active dose, or is it, a dud dose? Does it really alter the structure of the organ? For example, does it affect the heart or not, causing heart failure? And before these people are diagnosed with heart failure, can we pick them up early by doing screening tests like echocardiograms before they present with that overt heart failure? So these are the touch points for studying susceptibility, individual susceptibility, and we are harnessing this in several studies here. This is one of them. This study is open at 100 different sites, and I have received a fair amount of funding from the National Cancer Institute, the Leukemia Lymphoma Society, to study this particular question. At those 100 institutions, when a childhood cancer survivor comes in and has a particular complication, which we call a key adverse event, we enroll them on our study. At the same time, we identify another childhood cancer survivor who doesn't have this complication. And we match them very carefully to make sure that they're alike, except for the fact that one has the complication and the other one doesn't. From both, we request samples, blood samples for DNA. We ask them to complete a questionnaire, and we ask the treating site to give us a summary of the exact amounts of treatments that the child received. And with this, we are studying certain complications that develop in childhood cancer survivors, such as stroke and second cancers and congestive heart failure and osteonecrosis. So here we're going to talk about heart failure or cardiomyopathy. Let's see what are the risk factors. The primary risk factor is this particular kind of chemotherapy, which I had mentioned earlier, the anthracyclines. There are other reasons for this patient to develop heart failure. These include chest radiation, a very young age at exposure, such as less than 5 years of age. Females are at a higher risk, and then having other complications such as diabetes or hypertension or high cholesterol, which increase the risk of anthracycline-related heart failure. This is just a simple cartoon diagram to show you that the higher the dose of anthracyclines, the greater the risk of developing heart failure. And there's this magical dose number called 250 milligrams per meter squared, above which suddenly the risk increases a lot. Just to give you a magnitude of the risk, about 60% of children who are exposed to this high dose of anthracyclines develop echocardiographic evidence of heart failure. And once heart failure develops, the 5-year survival is not so good. So the important thing is to make sure that we understand why it's happening. This slide is just to remind me to tell you that not everyone who gets the high dose of anthracyclines develops heart failure, and not everyone who gets a low dose of anthracyclines escapes the development of heart failure. So cases are people, are childhood cancer survivors with heart failure. And here is the dose. Below this is low dose anthracyclines. And here each green dot represents a person with heart failure. And what I'm trying to show here is that we understand that those who received a higher dose of anthracyclines are likely to develop heart failure. But look at the large number of people who received a lower dose of anthracyclines and yet developed heart failure. On the flip side, these are controls, i.e. childhood cancer survivors who received anthracyclines and never developed heart failure. gutting this at 250 milligrams per meter squared again. And what you find is that the fair number of them had high doses of anthracyclines and yet did not develop heart failure. So this is what piqued our interest in terms of studying, could genetics be playing a role? So this is the group of children who had heart failure, 170 of those. Those who didn't have heart failure, 317. Just to give you a flavor of what this population looked like. The age, the average age at which they were diagnosed with their primary cancer was around 7 years. At the age when they participated in our study, about 17 to 18 years. About 73% to 79% were white individuals, but we had a fair mix of other races and ethnicity as well. These were the primary diagnoses for both the cases and controls: bone tumors, lymphoma, acute myeloid leukemia, acute lymphoblastic leukemia, soft tissue sarcoma. These are the kinds of conditions that get anthracyclines. Important to note that when you look at anthracycline exposure, higher doses of anthracycline amongst those who develop heart failure versus those who don't, more people are likely to receive just radiation as compared to those who didn't develop heart failure. I don't think I will go through the slide, but enough to say that this is a framework that we had developed as to what would be the pathway from high doses of anthracycline to developing heart failure in order to solve that puzzle at the DNA level. And so I show the slide in 1 minute, but this is 20 years worth of work. And these are all the genes that we identified, which showed that those who had specific mutations in those genes were at a higher risk of developing heart failure, and some more. And here what I show is, this is a cell in the body. And what we show is that with these genes, we can say that indeed we are bringing this issue of heart failure into a sharper focus. So can we harness all this information in identifying those who are at the highest risk? And yes, we can. And this slide just shows us that we can use this information in developing tools to predict who's going to be at the highest risk. To walk you through this straight line represents flipping a coin. That if I were to have a childhood cancer patient, I would say, I'm flipping a coin to see whether in the long term you're going to develop heart failure or not. So this is not a very good prediction tool. If we look at people who received anthracyclines and I factor that into it, you get somewhat better prediction ability. But if you add the genes into the model, you get a much better predictability, i.e. you are 84% sure that you can predict whether a person is at risk for developing heart failure or not. Can we do anything for those who are at the highest risk to develop risk, to use any medications to reduce the risk? And yes, we can. We did this in a study where we ran a trial. We randomized people to low dose carvedilol. It's a beta blocker that we use to treat blood pressure. And the other half of the people got a sugar pill. And we gave this for 2 years, monitored them with echocardiograms and with blood biomarkers. And we showed that those who were at high risk for developing heart failure were the ones who were most likely to benefit from this carvedilol. And we're now trying to see if we can take it out into the general population, into the clinics. I'm pivoting now to second cancers, a devastating complication. You've gotten treated for a first cancer, and in a few years you develop a new cancer, a second and then a third cancer. I'm going to talk about brain tumors first. So childhood cancer survivors are at a 10-fold higher risk of developing a new brain tumor compared with the general population. These are in the form of gliomas and meningiomas, and the survival is really not good. It's less than 20% if they've developed this particular glioma. Who is at high risk? It's those treated with radiation, especially at a very young age. And here we're talking less than 5 years of age. And what I want to show you here is that there's a linear relationship. Here's the risk, here's the dose of radiation. The higher the dose, the higher the risk for both meningiomas and gliomas, the two types of brain tumors that we commonly see in our childhood cancer survivors. Again, the same story about varying risk in different people, no matter what dose you're using of radiation. Here are cases who developed brain tumors at low doses of radiation. Here are controls who escaped developing brain tumors, even though they got higher doses of radiation. So we collected a bunch of genes and said, let's see if these genes increase the risk of developing radiation-related brain tumors. And indeed, we found these particular genes that increased the risk by 1.6-fold to 4-fold when compared to people who didn't carry the mutations in these genes. These genes are primarily responsible for repairing the DNA in a person once the radiation breaks down that DNA. So this is the cartoon I would use to explain how people develop brain tumors. They get radiation to the brain. Two brains are getting radiation, both of them because they need it for their primary childhood cancer. Once the radiation hits the brain, everybody, no matter who, will develop what's called a mutational burden. The DNA will get mutated in everybody. But nature has provided us with a mechanism to repair that DNA very efficiently, very nicely, very fast. But some of us are unfortunate where we aren't able to repair our DNA properly. And this leads to lasting effects in the form of mutations that linger. Some of these mutations develop a growth advantage, and then that becomes a new brain tumor. And this is what we showed in our particular study. Can we use this to identify who's at high risk? And again, showing you a similar figure that those, when we combine genetics with the clinical factors, we find that we have about 81% certainty in identifying those who are at the highest risk of developing brain tumors in this setting. Can we do something to reduce the risk of this complication? Now I'm talking to you about radiation-related breast cancer. Here, what I'm showing you is radiation increases the risk of breast cancer. Young girls with lymphoma who needed to receive radiation to the chest to shrink the lymphoma nodes developed breast cancer afterwards. Again, the higher the dose of radiation, the more the risk of developing breast cancer. Also, what we found was that by the time these girls were about 45 years of age, 1 in 5 developed breast cancer, and this risk is similar to the BRCA mutation carriers. So not a good situation to be in. What we also found was that amongst those who had received radiation, if we had given them high doses of ovarian radiation, the risk was blunted, as opposed to those who got no ovarian radiation or little ovarian radiation. What it meant was that these girls needed estrogen to increase the breast cancer risk. And could we use an estrogen blocking agent to reduce the risk? And we did that. But before going there, let's see, are there other options that are available to us to reduce the risk? I mean, one way to do it is to do prophylactic bilateral mastectomy. BRCA mutation carriers do that, and there's a 95% risk reduction. But our childhood cancer survivors are not comfortable with this option. We could remove both the ovaries, but removing ovaries has major risks there's osteoporosis, there's high cholesterol, there's heart disease. We don't want to take this risk lightly. We could use some medications. There are two options. One is called tamoxifen or SERM, and the other one is aromatase inhibitors. The second option is approved only in the postmenopausal setting, but our childhood cancer survivors are not all postmenopausal. So we are left with tamoxifen, and that's the thing that we focused on. And then we used some biomarkers. One of them is if you look at mammograms and use mammograms to see what the density of the breast is, it tells you whether the risk of breast cancer is reduced or high. The other thing with tamoxifen is if you use it in the regular dose that is used for the older women, it is associated with a lot of gynecological symptoms and menopausal symptoms, and it is also associated with cancer of the uterus. If you use low-dose tamoxifen, it doesn't have these risks, but it does reduce the risk of breast cancer. So we did a randomized trial. We gave 5 milligrams of tamoxifen, the low dose, for 2 years to one half of the patients and the sugar pill to the other half. And we measured their mammograms before at 1 year and 2 years. And we showed very clearly that those who got the tamoxifen had lower risks of breast cancer, both at 1 year and 2 years, as compared to those who got the sugar pill. Now, the next question is, if we identify people at high risk, can we screen them? So we detect that complication early, and then we can manage it at a faster rate. Yes, we can. We've developed what we call long-term follow-up guidelines. They're in their 6th version right now. We developed them 20 years ago, and every few years we update them and refine them. And these guidelines tell us that if you got radiation to the chest, you need to do X, Y, and Z in order to make sure, for life, in order to make sure that we can detect these complications early. Can we change the upfront treatment to prevent these complications from happening? Over the decades, yes, we've done that. We've either eliminated or reduced the dose of radiation to the brain. We've reduced the chest radiation for Hodgkin lymphoma so that we can reduce the risk of breast cancer and other complications. We've reduced anthracycline dose. We've reduced alkylating chemotherapy dose. All of these things we're doing very carefully because our major first primary goal is to make sure that we don't compromise the survival. But we do want to make sure that we can really arrive at that fine balance where we maintain a good survival, but reduce the risk of long-term toxicity. Has this had an effect? And yes, it has. For people who were diagnosed in the 1970s, their death rate was much higher. It got lower in the 1980s and much lower in the 1990s. When we look at death from complications, again, the same story. 1970s, higher death rate, 1980s, lower, 1990s, even lower. So then the question is, are we there yet? And the answer is not yet, but I think we are solidly on the right path. And I do want to thank all my funding agencies as well as my group here at UAB and Children's who helped me in doing all of this work, because this is not a single person's work. Need to thank the patients and their families, most importantly, because they give willingly of their time, of the samples, everything in order to make the lives of the future generations better. And then I'll be happy to take questions.
It's just a fascinating presentation to just seeing where we are going with cancer research and what's going to happen. Open it up for questions. If you have questions, drop it in the chat. We will ask Dr. Bhatia. So I'm going to throw one at you on topic, but kind of off topic. Where does the interest for you come from for this research? Where does this stem from?
Yeah, usually, if you ask this question from 100 different researchers, I think 95% will say serendipity. How did it start? I was training in pediatric oncology at the University of Minnesota, and what I would call as the biggest expert in cancer survivorship became my mentor. And as he became my mentor, I started working on projects with him. And early success in getting strong publications, discovering findings, got me hooked onto this. And since then, it's been a path, a journey.
So is there a difference between those who have received proton versus photon radiation?
You ask such good questions. In order to have answered that question, we should have studied that question in the setting of a randomized study, putting half the patients on photon and half on proton. That never happened. And because it didn't happen, the horse is out of the barn. Stable? Is that what it is? Wherever. And I don't think we'll ever be able to answer that question. In theory, protons should be better, but we don't know the answer.
As I said, if you do have a question, go ahead, drop it in the chat. We have questions coming in. Are there any AI diagnostic algorithms to predict treatment and survival?
I think you were a fly in the wall in my office all the time. We just got funded to develop a chatbot using AI technology in order for a community pediatrician or primary care provider who sees a childhood cancer survivor to be able to say, hey, Google, or whatever that chatbot will be called, can you please tell me, how do I follow this young girl who received chest radiation at age 15? And that would tell us, based on the guidelines that we've developed, immediately, you need to do a mammogram and an MRI starting now and every year until this age. So that is what we are doing right now with the AI.
And you're too kind to think that I'm coming up with these questions on my own.
This is the chat bar. Wrong.
That's okay. I appreciate it. I'll give myself a pat on the back, but no, we have a great audience asking these questions. So please define milligram versus M2 milligrams per meter squared.
Say that again.
Please define mg/M2 milligrams per meter squared.
I don't understand the M2 per meter squared, but M2 means meter squared. So what I'm saying when I say mg per meter squared, I'm saying that everybody who comes to us as a child is not the same size. So what we do is we use their height and their weight to calculate their body surface area. And we give them a dose which standardizes based on their body surface area. So we would prescribe, say, 50 milligrams per meter squared. And if that person was 1.5 meters squared body surface area, they would get 75 milligrams of the dose. That's what it means.
And if you do have questions, continue to drop them in the chat. How much do items like nutrition and environmental factors impact the work that you're actually doing?
So this is a question that is being more recently asked. It was not asked for the longest time. I mean, intuition would tell us that if you were severely cachectic, you would have a higher risk of complications. But what we are now studying is your body composition, meaning your skeletal muscle mass and your visceral obesity and adipose tissue and your subcutaneous adipose tissue, are they determining what toxicities you will have? And those in turn depend on your diet and how much you exercise. So questions that are being asked. Then the environment, we are also asking the questions out of our what we call social determinants of health. We are asking for air pollution, water quality, the neighborhood food deserts. All of these questions are now being asked and systematically being answered. So when you call me again in a year or so, maybe I'll be able to answer them.
Are there differences internationally in survival rates, and primarily between developed countries? Apples to apples, not apples to oranges.
Yeah. Minimal. So if we were to say, are survival rates better in Britain versus the US, the Great Britain? I would say minimally. And even if you really do truly, Washington apples to Washington apples, yes, hardly any differences, because very similar treatments are used in all those countries. Now, developed versus developing countries, that's another story. Yeah. Mm-hmm.
What % of overall deaths are due to recurrence of the primary tumor?
Yeah, so it's a very nuanced question. So if we were to first talk about childhood cancer is not one single cancer. There is leukemia and lymphoma and brain tumors and different types of brain tumors and other kinds of kidney tumors and everything. So the survival rates vary from about 10% in certain really bad brain tumors to over 95% in Hodgkin lymphoma survivors. So all across the board, but luckily the people who have very low survival rates are a small number. And so if you look at childhood cancer overall, the survival rates are 85%. Adult cancer survivors, the survival rates are approaching 70%, but again, with the same kind of difference, pancreatic cancer, not so good. So certain types of breast cancer, very, very good. So different outcomes for different cancers.
Is there any way to treat expected complications before they may happen?
Yes. When we say expected complications, we are meaning complications that have started on their road to becoming complications, but they're not visible. You can't see, you don't have symptoms as a result of that, and you don't have signs when a doctor examines you. Those complications can be prevented, and I showed you two examples. One was the low-dose carvedilol, and one was the low-dose tamoxifen. And our goal is to prevent them from happening. And our goal is to get that particular kind of prevention out into the clinics soon.
Are there racial ethnic differences that have been well defined?
Yeah, there are. But at the bottom of it all, it boils down to socioeconomic status. And it boils down to certain groups having more comorbidities. And because of that, that being ascribed to race. So there really, all of those are the underlying unfortunate lived experiences which lead to those differences.
And thank you for all the questions. We have a very active chat. With regard to the need of early detection of complications in the cancer survivor, how often should a survivor be evaluated routinely?
Yes. If I were to have my druthers, every year for life. And that's why we've established survivorship clinics here at UAB. For children, we have a survivorship called TLC, Taking on Life After Cancer. And we see our childhood cancer survivors once a year. And I tell them that we will see them till I'm gone, i.e. gone from the face of this earth. So,
with the work you are doing, is there a website people can go to support what you're doing?
Love that. We have on the Institute for Cancer Outcomes and Survivorship website, we have a place where the work can be supported, and I am humbled by somebody asking this question. The work can only go faster if we have funding.
And I am pulling that up on the side screen now. I will plop that into the chat here in a moment.
Thank you.
Cancers used to be defined by a location. Seems that it is not quite so true anymore. Any insights on how we may categorize cancer 10 years from now?
Yeah. Cancers are, so as the technology is advancing in terms of getting into the cell and trying to make out exactly what's going on. Cancers are being split. That pie, which used to be just 4 pieces, is now getting into smaller and smaller slices. So a lung cancer, because of the way it originates, might be lumped now with a particular kind of a lymphoma, because the DNA level at which that particular cell became cancer is a cousin of that particular cancer. The 2 cancers are related, and so the treatments are similar. So 10 years from now, we won't be saying somebody has lung cancer or somebody who has a brain tumor. We will be talking about a rasopathy, because KRAS mutations are happening in different sites of cancer, but they have an underlying common mechanism of developing. So very good question.
And I did put that link in there, uab.edu/medicine-icos/give. Any benefits of prayer, spirituality, etc. in your cancer patients?
Absolutely. So when we study their quality of life for childhood cancer survivors as well as adult cancer survivors and the parents of childhood cancer survivors, we find that the resilience and the ability to really overcome the major issues are so related to their spiritual well-being. In fact, we recently published a study where we asked them one single question: how do you rate your health? And they were allowed to rate their health as poor, fair, good, very good, and excellent. And those who were rating their health as poor, fair, or just good had a worse survival than those who were rating their health as a better outcome. And this is after leveling the playing field for all the complications that they had. So spiritual and internal well-being is definitely a factor in terms of long-term survival.
Are there families in which there is more than one person who is diagnosed with childhood cancer for genetic reasons?
Yes, and we are currently studying that. What we are looking at is what are called pathogenic mutations. So 10% of childhood cancer is because of these mutations. You carry a cancer predisposition in 10% of childhood cancer. And what happens is that mutation then carries forward. So you give them radiation on top of that, you're really sprinkling salt on the wound. And that increases the risk of second cancers and third cancers. So yes, once we diagnose a person who has a childhood cancer with cancer predisposition, not only do we need to make sure that all their family members are checked out, but also that we really intensify their follow-up to prevent future cancers from happening.
Is there a way to maintain an alkaline body similar to cancer treatment drugs?
Not aware of that. No.
Well, Dr. Bhatia, thank you so much. It's a very serious topic, but it's one that everybody's affected by. Everybody is touched by cancer. So thank you so much for spending your afternoon with us, your lunch hour with us, to go over this important topic.
Thank you so much for having me. Really
you are so welcome. And just a reminder, we will be uploading today's webinar onto our website. When it's ready, live attendees will get an email with the replay link. In a moment, I'll highlight a few other webinars we have coming up in our series. But first, we'd love for you to join us as we support scholarships through Uncork Education on November 14th. This year, we're hitting the road to the Florentine in downtown Birmingham. Help raise money for scholarships through auctions, beer and wine tasting, and Blazer Plinko. Tickets are $60 and can be purchased by visiting alumni.uab.edu/Uncork2024. As for those next few webinars on our schedule, on November 13th, Dr. Kaylee Crockett will be with us for values-based self-care for the holiday season and beyond. Come back as we gain a better understanding of the importance of aligning self-care with personal values. Then on December 3rd, join us for Sweat for Sanity, exploring the transformative impact of exercise on mental health. Emily Marzolik will provide ways to help reduce stress, anxiety, and depression through movement. And on January 9th, our first webinar of the new year is Taking Charge of Your Career, Improving Confidence. Amber Grant and Tammy White will be here to explore imposter syndrome and share what we can do about it. Register for these and keep an eye out for more. We have a whole bunch coming up in the new year at alumni.uab.edu/events. Finally, we value your thoughts. The QR code that's on your screen will take you to a short survey. Let us know your thought about today's webinar and what you'd be interested in seeing down the road. Once again, thank you so much for joining us. And as always, go Blazers.